Alrighty, I guess we've gone through C, we've gone through prep. Now it's my opportunity to take you through treat. Thank you very much for the opportunity to speak at the third annual Sky Bangladesh course. I remember last year was a lot of fun, and this year we had earlier in the day a completely packed house. So it's a real privilege to be here. These are my disclosures. So what's the formula for success in PCI, right? We've already heard a lot of the guts of how it's defined. It begins with an intravascular image that gives us the information we need to make our best decisions. The angiogram gives us a general guide. The intravascular imaging gives us the details necessary to separate one piece of equipment from another so that we can select a square peg for a square hole. Through the imaging, we get the vessel anatomy, we get the lesion anatomy, and then we go to our toolbox to select the right tools to achieve our optimized result. And so ultimately, this process simply boils down to see, prep, and treat. So does treat then just mean optimize the vessel and throw a stent in? Or take a vessel and balloon angioplasty it when it's prepared? Or is there a nuance to which stent you use and when and why? Or when you use a drug-coated balloon and why? So I'll use this case that was from a little while ago to help illustrate that point. This is a 76-year-old guy, South Asian, the usual cardiac risk factors, presenting with low threshold chest pain and really, really bad kidney function. His creatinine was 3.1. He had allowed it to get this bad without revascularization because nobody would let him get a cath, being told over and over that you're likely going to pooch your kidneys and end up on dialysis, so we're not going to send you, just deal with medical therapy. Unfortunately, he comes in with an acute coronary syndrome. These are his right coronary arteries. Not so bad. And then this is his circ and his LAD left main system, right? So he's got a tight lesion at the bifurcation, right at the ostium of both vessels. He's got a bunch of disease coming all the way down the circ. He's got a subtotal occlusion of the OM, and the LAD looks awful proximally. So one of the operators at our institution, when this guy was sitting on the ward for 4 or 5 days, now getting chest pain at rest, gone in and did a, quote, get out of trouble intervention. As you notice, there wasn't much in the way of a left main. So this is the one circumstance where maybe an SKS type approach is a reasonable approach as a bailout in this patient with no left main. And he took very high pressure, 3.2 millimeter NC balloons at 24 atmospheres. And as you can see, these open. They open reasonably well. And then they set up for SKS and they performed SKS with a circ, with the circ and the LAD. This looks reasonably well expanded, save this tiny little segment here. You're not totally convinced, but you know what? The vessels are open. They're 3.5 stents, post-dilated with a 4.0 NC balloon. This is your final result in 28 cc's of contrast. Not bad, right? It got the guy out of trouble. But did we treat this, or did we palliate this? Did we placate this problem until it shows up again? That's the question we always ask ourselves, right? When's the most important PCI that our patient has? It's the first one. And that's why we've got to see, prep, and make sure that we treat optimally using the very best tools at our disposal. So I got a call from him shortly thereafter, after this final result was achieved, saying, hey, I got him out of trouble. Can you take care of the CTO? Shouldn't be a problem with the rest of the proximal vessel. And I said, okay, no problem. What were the MSAs in the osteal LAD and osteal circ? Because this is effectively a left main equivalent. And he said, dude, I have IVUS eyes, so I don't really need to do that, right? I made them big. And so I shook my head and I said, no problem, let's just take him to the case. But these are the dangers of the optimal angiographic result, right? This is a great angiographic result, right? It looks really nice open. The problem is we make decisions based on angiograms that drive us in a particular direction. The consequences of making a bad decision by undersizing are small because you don't get to see them. You don't get to see underexpansion unless it's gross while the patient's in hospital. But of overexpansion or oversizing, well, those consequences are pretty clear, right? You perforate the vessel or you dissect something. But the reality is that when you lay out angiography versus IVUS, this is not a great correlation. There's a general idea given to you of vessel size by the angiogram and of vessel expansion by the angiogram, but it's not perfect by any stretch of the imagination. And so sizing without IVUS affects our behavior because we tend to choose smaller stents. They end up undersized, and then as a result, our patients have unfortunate outcomes much shorter on in their clinical course than they should. So heuristics drive choices, right? It's an early win, patient gets off the table, but at the cost of a late loss, because 1 in 8 of these people, particularly in the left main, is going to need to come back for another intervention at less than 5 years if you don't expand them well and you don't size them appropriately. And that's why seeing and prepping appropriately is so important. So now we come to our intervention, which was a zero contrast CTO, right? Or at least that's what we thought. How do we treat this? Well, we have a series of decisions to make, right? We see, right? So what was the previous result like? What was the osteal lesions like, and were they well expanded? We prep, right? So what are the wires that we're going to use to cross the CTO? Are we going to need to atherectomize? What are the balloon sizes we're going to need? And then what are the order of vessels that we're going to treat? And then we treat. So this is where it comes down to using your tools to create your strategy, right? Do we 2 stent? Do we 1 stent? Do we DCB? Do we leave the CTO alone? Right? Are we going to give this guy complete revascularization with a creatinine of 3 if, we're going to have to use a ton of contrast? And then finally, of course, let's check our result and make sure we do a good job. So this was our initial wiring and our initial IVUS. This is playing back from the circ back towards the ostium. And what you see is that there's gross malapposition underneath the stent, and then there's even worse under expansion as you get proximally. Ugh, yuck, right? That's awful, right? And this is a sitting duck for a stent thrombosis now because the very proximal part of this vessel had a minimal stent area of just south of 6, right? So gross malapposition and gross underexpansion. How do you treat this problem, right? There's your severe malap. This is your severely underexpanded segment, but telling you that you have relatively thin calcium behind it. And so because of the natural reverberations, you're probably going to be able to re-expand this to an acceptable result. So when we saw the malexpansion and we saw the underexpansion. So how do we prep this? Because remember, we haven't gotten to our intervention yet. We're still cleaning up the mess from the first one. Well, thick calcium is on only one side. Thin calcium is on the other. So an ultra-high pressure balloon inflation should take care of this. And distally, you need a standard NC balloon at low pressures to fully expand it because there's no barrier to getting the stent expanded. It's air. It's just you've got to make it bigger within the stent tolerance. So that was an easy fix, right? These were 3.5 millimeter NC balloons distally and then an OPN balloon more proximally at high atmospheric pressures to fully expand to give you now a much more reasonable, much more respectable IVUS result. And this is that exact same vessel. Right? So no underexpansion now, fully expanded. Now let's move on to our CTO, right? So here's what we learned from seeing. We see that as we come back towards the diagonal branch, there's no disease really at the diagosteum. There is a landing segment, or at the OM osteum, there's a landing segment there. So recognizing then where the segment is for zero contrast, right? We have to fluoroscopically co-register it. And recognizing that it's calcified, but there's also plaque, we want to use a soft wire to enter. So we use a workhorse wire, and we make a crossing decision. Lots of calcium in the circ, but minimal at the diag. And so we're going to use a workhorse wire to enter, bring a microcatheter forward, and then use a simple hydrophilic wire to cross. All of this stuff we learned, all of these treatment and prep aspects we learned just by seeing. So we saw. As you can see, we crossed. It wasn't particularly difficult. It took about 10 seconds. And now we're able to treat. So now we've got to mark the bifurcation. So here we pull our IVUS back from the OM back into the main branch. So we're seeing again, right? Now we're going to have to prep this because there's a large plate of calcium and then some plaque coming back into the circumflex. So how do you want to prep it and treat it? And how are we going to check our results? We've got disease within the diag, it's coming back towards the ostium. The OM. The OM and the proximal circ are about the same size, and there's a bunch of distal circ disease as well. So this is sort of a complex bifurcation where you have disease in the branch that's longer than 10 millimeters, the angle's less than 70 degrees, and the vessels are, for what it's worth, reasonable size. So I chose a 2-stent strategy here.